Time.
Okay, shall we start?
Yes, we
China.
on time.
China.
Co-chair is already here. For today,
Okay.
Professor Chen is not available because he occupied in OR, so he's still on surgery. So he's working on surgery. So I think today another Professor Wang Zhijian is going to replace Professor Chen to co-chair with you, Dr. Wang. And while we are still waiting for the first speaker, maybe we start from the Dr. Mahmoud Trainer. Maybe we start first. Yeah. Okay.
We start?
Yeah, we can start. Give it to you. Okay. Always very graceful now.
Okay. Good morning and good afternoon to all our colleagues watching this Asia Pacific Society of Cardiology webinar. And this is the part 2 of our series, Acute Coronary Syndromes, part 2. And today we'll be discussing a lot of controversial issues in STEMI, non-STEMI, which is one of the major important diagnosis that we see as cardiologists. There's a lot of issues that we are going to discuss, including primary PCI versus thrombolysis, delayed or early PCI in non-STEMI, complete or single revascularization in STEMI, and also patients with shock and the patients with the young MI. My co-chair is Dr. Wang, who is Associate Professor of Cardiac Surgery at the National Taiwan University Hospital. We have 4 speakers today from different parts of Asia. We have Afzal Rahman, who is from Bangladesh, and he is the director of the National Institute of Cardiovascular Disease in Dhaka, Bangladesh. We have Dr. Mahmoud Trainer, who is director of the Cath Lab at Cleveland Clinic, Abu Dhabi. We have Masato Nakamura, who is professor of cardiovascular medicine in the Ohashi Medical Center, Tokyo, Japan. And finally, we have Kok Han Chi, who is professor of cardiology at the University of Malaya, Kuala Lumpur, Malaysia. We will start with Dr. Mahmoud, and he is going to talk about acute STEMI complicated with cardiogenic shock, keys to decision making.
Let me just share my screen. Okay, thank you, Dr. Weil and Dr. Wang, for the introductions. Honored to be here with you all today. And it's a kind of a complex topic, but hopefully I can shed a little bit of light on it in the time that we have. I have no disclosures relevant to this talk. So basically, there's a few key questions I think that we need to try to emphasize in this setting in patients with acute MI and cardiogenic shock. So I think this seems like a clear answer, but I don't think the data really shows this, but is hemodynamic support necessary? And if we do so, which device is best? More recent question comes up is, do shock teams help? And then finally, should non-culprit vessels be treated in the setting of acute shock? So the progress in innovation in cardiogenic shock and adoption improvement has been a slow process. The first balloon pump was developed 54 years ago, inserted by a surgical cut down, had really limited use. Mortality was over 80% at that time. Then in the 70s, we got the development of initial balloon angioplasty and primary PCI insertion of balloon pumps, and mortality started to come down. By the late 90s, the use of primary PCI was, at least in the US and most of the world, has steadily increased, and the use of balloon pumps steadily increased, and mortality was down to 50%. But basically since then, it's been at a relatively steady state up until more recent. We finally got a randomized trial, a large randomized trial in 2012. So there was 23 years from the first PCI use to first randomized trial in cardiogenic shock, and it took 46 years for the first balloon pump large randomized trial to be done. And another issue with these patients in cardiogenic shock is the extremely small sample size that we see in trials as compared to other areas of cardiovascular care. And this is kind of just a sample size of some of the recent dedicated trials. And if we look at these, the total in the last 2 decades, only about 2,500 patients with shock were randomized worldwide. So only 0.05% of acute MI with shock worldwide were randomized. So we have a very limited, sparse database to kind of work with in terms of actual randomized data. And a lot of the commonly used therapies we use in shock are not subjected to randomized controlled trials. So right heart catheterizations was not studied in shock, was studied in stable heart failure patients. Inotropes like dobutamine and milrinone are commonly used. There's no randomized data looking at these with specific anticoagulation, antiplatelet agents, IV agents like bivalirudin or Cangalore, not studied in shock. Stent usage was not studied in shock. BMS was used in the shock trial. ECMO therapy up until recently was not studied in shock or arrest patients. So it's been a difficult area to tackle, and I think a lot of it comes from the definition of shock and how do we define a patient, and patients change their status pretty quickly in these sick patients. So the SKY came up with a classification recently, last year, for classifying shock, and this provides twofold. One, a way to approach these patients in a more systematic way, but secondly, it also allows for developing of trials targeting various levels, and maybe not the therapy for each stage of shock shouldn't be the same. So it's kind of a pyramid shape where at the bottom you have patients at risk. So these are patients that have large MIs, acute and chronic heart failure, but are not having any signs of symptoms of shock. Stage B is those that are beginning stages of shock, so they're starting to get a little hypotensive, relative hypotension, but they're still perfusing, still mentating well. We start to get to stage C, where we have the true classic shock. So that's where patients have evidence of hyperperfusion, they're not mentating well, there's evidence of organ involvement, they're needing support with inotropes and pressors and other support. And then stage D is the same as the C, but they're further deteriorating, so they're getting worse. They continue to progress. And then finally, stage E is the extremis or circulatory collapse. This is patients with refractory cardiac arrest, persistent CPR, kind of advanced stage, end stage shock patients. And then when we look at device therapy, so does one size or device fit all of these classifications? So there's 3 stages of devices that there's plenty of devices that are used in shock. We focus on the left ventricular support devices. Basically, the primary devices are 3. So we have the balloon pump, the old and tried and true device, easy to put in, affordable cost, it's relatively small French, but provides a pretty low amount of actual cardiac output support. Impella, which is also pretty easy to put in, a little bit larger sheath size, more support in the 3 to 4 liter range. Cost becomes more of an issue with this device. And then finally, we have the maximum support of VA ECMO, which can provide up to 7 liters of support, but needs large bore arterial and venous sheaths to put in. Now, the variability of usage of support devices varies. So this is just kind of a sampling from the trial we'll talk about later, the culprit shock trial, looking at multivessel PCI in cardiogenic shock. And in this trial, which is mostly a European trial, mechanical circulatory support was only used in 28%. And it kind of varied across the subgroups. So some patients got balloon pump, a quarter of those that got devices got balloon pump, about 40% got Impellas, a couple got tandem hearts, and ECMO in about 20%. So it's still kind of a variable what people use and still somewhat underused. Now, if we look at the US trends of use, balloon pump usage has pretty much stayed the same over the, from between 2004 and 2011, but there was a dramatic increase in the use of percutaneous mechanical circulatory supports, meaning Impellas and its analogs, and ECMO use, and that's dramatically increased. Now, if we look at it, this is the number on the left side is of the mechanical devices versus the right is balloon pump. So balloon pump usage has stayed stable around 50,000. These devices have trended up to about 3,000. So we're still talking small numbers, but again, with all the confounders, there does seem to be some improvement in mortality rate seen with this. Now, when we talk about the randomized trial, the first randomized trial was the CRISP-AMI, which is a relatively small trial looking at balloon pump in patients without shock. So these are patients with large anterior MIs, So more of a, if you go back now, obviously it wasn't at the time, but more of a stage A or B kind of patients. And this, again, was a small trial, but did show a trend towards significant reduction in the combined endpoint of death, shock, or new or worsening heart failure. So kind of some support for balloon pump maybe in the early phases of shock. The IABP shock trial was a randomized trial in patients with full-on shock and looked at 1-year all-cause mortality. And this was kind of a surprising result in 2013, which showed no benefit to the use of balloon pump in shock patients. So when we look at the predictors of mortality in patients with shock in this trial, and I want to try to explain what is negative, the two strongest predictors were age and stroke, and those were both not modified by any acute intervention. So those are fixed outcomes. But if we looked at the next three main modifiable risk factors, lactate, oliguria, and pH, those are all signs of the degree of shock. And so those all suggest that if we support more, maybe we could have gotten more benefit in those patients. But if we look specifically at Impella and the randomized trials to support its use, it's been extremely challenging to randomize in these trials. So almost all the trials were discontinued early due to lack of enrollment and difficulty in getting these patients into these trials. And I think this is a kind of a worldwide problem where we're having trouble getting patients into randomized trials for shock. Now, with all the limitations of these being small studies that were discontinued early, when they compared mechanical circulatory support to balloon pump across these trials, there was no benefit in mortality. But if we look at the kind of groups of patients, so the patients with more hypotension, lower blood pressure favors mechanical circulatory support, and those with higher lactates favored mechanical circulatory support. So if we targeted the sicker patients in these trials, there may be a signal that there's benefit to mechanical circulatory support. So if we kind of look back at the SKY algorithm and try to come up with an individualized device approach, kind of a reasonable approach would be to consider in the class A and the stage A and stage B patients, balloon pump may be a reasonable option for these patients to support them through their initial shock while the MI is being treated. For the more advanced C and D patients, Impella may be a good choice, and these are the patients that are going to have signs of hypoperfusion and may benefit from higher levels of circulatory support. And obviously for the extremist patients, I think that's where we need to start considering ECMO. So when we look at clinical objective supports, obviously there's two components. We need to get coronary perfusion, and we need to get circulatory and ventricular support. And that's where the percutaneous support devices help. So there's been a big push, I think, in the last 5 to 10 years about trying to develop more of a systematic approach, and protocols and pathways are a key. Now, this is one algorithm promoted by Bill O'Neill and the National CSI group in the US, but trying to develop a algorithmic approach to cardiogenic shock. So rapid identification, activation at the cath lab, getting femoral access, standardizing the approach across operators, early identifying these shock patients, using hemodynamic-based assessment, and early institution of mechanical circulatory support as needed, with reassessment and escalation and weaning as needed. And this is kind of their data. Again, these are data obviously that's going to be hard to compare and hard to decide, if it's really from intervention or it's the data collection. There's a lot of confounding factors. But with this kind of method, they've been able to achieve a 28% mortality compared to more historical controls around 50% with this kind of usage of this kind of algorithm. It's been similarly seen in other groups. So the Wellstar group's a big hospital system in Georgia and the US. And when they instituted a cardiogenic shock algorithm using the CSI model, their previous mortality was around 50%. And their survival was around 50%, and survival was able to increase to 70%. Again, with a referral system, all shock patients from the smaller hospitals got transferred into the larger referral center to manage these patients. Similarly, with the Innova Shock Registry, another group, again in the Northeast US, they saw similar findings. So when they instituted a shock protocol and a shock team and algorithms, they were able to improve their survival from around 44% with acute MI up to 80%. And even with acute decompensated heart failure, able to improve it from 60% to 72% with a significant amount of additional lives saved. So what are the limitations in shock care? I think this is to me is equally as important as the choice of device and support that we use, is that there's a lot of systematic issues that limit our shock care. So there's fractured care. You have surgeons in one silo and cardiologists in another silo, and ER and intensivists in another silo. So developing a formal process for multidisciplinary evaluation of the patients, trying to improve communication across all these disciplines that are integral for the patient's care. Patients are often detected very late. So by the time people are considering advanced therapies for these shock patients, they're often too sick and it's too late to really for them to benefit. There's impaired access to care. So this is systems in transfer, delays in transfer, late recognition at the maybe the smaller hospitals that will transfer out, and then variations in care. So every provider and every physician and every center kind of does things differently. And so they have different systems to monitor, and leads to issues with the care. This is kind of just one example that I really liked that we're looking to model our own shock team on, but from the Innova group, where they kind of had a systematic approach, team-based, hemodynamic-based assessment, and again, can decide on the therapies that based on these criteria of for refractory shock, and kind of upgrading the therapy as needed. So obviously the specific, of each model can kind of vary of the specific therapies and what's available and what's cost dependent in your region and resources, et cetera, et cetera. I think those all can vary, but developing a local system to address these patients, I think will make a tremendous benefit for our patients in general. So next, when we talk about the other major issue is revascularization. So what do we do with in shock and multivessel disease? So, there's basically 4 approaches. You can do the culprit lesion only. That was the historic measure that we did with all acute MI patients. You could do the culprit lesion and then staged revascularization planned later for the other vessels. You could send them for emergency CABG, which I think at this point has been pretty disproven in terms of risks for the patient and the very high mortality, or immediate multivessel PCI. And this triggered a lot of interest because of the trials starting from the PRAMI and the culprit trial, where we saw in patients with STEMI, multivessel PCI dramatically improve patients. And if you think about it, you would consider, well, maybe if multivessel PCI helps in STEMI without shock, maybe with shock we'll have even more benefit. So a meta-analysis was done of registry data, so looking at multivessel PCI and cardiogenic shock. And in short-term follow-up, actually this favored doing only the culprit. And then when it was looked at in longer-term follow-up, again, no benefit. You could go either way. So the data was not clear, and a clear plan and recommendation based on registry data, and this led to the guidelines, which as of 2017, in the ESC, it was a 2A recommendation actually, based on the PRAMI and culprit and the earlier trials and the complete trial, that you can do multivessel PCI in the setting of STEMI. The ACC/AHA did not have any specific recommendations, but it did get an appropriate use criteria of A and a level of evidence of 9. So it was a pretty good criteria in favor of this, in spite of the lack of data in this specific subset of patients. So the culprit shock trial was a very nice trial, well done trial, published in 2017, looking at this specific group of patients. So patients with shock in acute MI, it wasn't just STEMI, but it also included non-STEMI, and saying if we treated all the non-culprit lesions as well, what would be the outcome? And they nicely looked at a combined endpoint of all-cause mortality or need for dialysis. And it showed a dramatic increase in the primary endpoint, so worsening of mortality and need for dialysis in patients that got immediate multivessel PCI. And this was primarily driven by a difference in mortality. So patients died more if non-culprit lesions were treated in that initial procedure. And this effect lasted out to a year. So it did not the curves did not come back to overlap. So there's still significant difference between the two groups of patients out to a year. And if we looked across all the subgroups, there's really no real trend to any subgroup primarily benefiting from immediate multivessel PCI. So across all subgroups, age, the amount of disease, STEMI or not, anterior or not, the trends all generally favored culprit lesion only PCI. So this led to a change in the European guidelines with an update in 2018, moved it to class 3 to do multivessel PCI in the immediate setting. This doesn't, of course, preclude later stage PCI after the patient's stable and improves and out of shock. But in the initial setting, that's what we get. So in summary and conclusion, the data on mechanical circulatory part and cardiogenic shock is mostly limited to registry data. And we really need to develop new approaches to data collection and to finding ways to randomize these sick patients maybe that are not able to give consent and finding ways to get better data in these patients. I think depending on your resources available, an individualized approach in a systematic way should be undertaken based on the cardiogenic shock stage. Understanding the hemodynamics is extremely important in decision-making, so liberal use of right heart catheterization, EDP, to kind of make these decisions. I think system-based approaches to shock with shock teams can improve outcomes. And then finally, fix the culprit and get out in the acute setting, get the patient stabilized, and then you can consider further stage PCI on a later basis based on clinical response. Thank you very much.
Thank you very much, Mahmoud. That was an excellent overview of the treatment of STEMI with shock. I'd like to open for discussion with our group here. Dr. Wang, I know in Taiwan you have a very well-developed ECMO program. What is your experience with ECMO and shock?
Yeah, well, in our hospital, we usually use the ECMO for such kind of cardiogenic shock. And because we have a rapid response team, so we can easily to put on the ECMO within half an hour as soon as we meet the patient. So in our hospital, our team experience is that when we met a cardiogenic shock and put on the ECMO for the MCS and then goes to the cath lab, if we cannot open the culprit region, or even we open a culprit region but the heart is still stunning or still VFVT, then we will directly move to the operation room to do the full total revascularization so that we can restore the heart functions as soon as possible. So we don't wait for the stabilized PCI, because it will lasting for days and probably the heart will lose more muscles.
Thank you. Any more comments or questions? Okay, with that, then we'll go on to the second talk today. Dr. Nakamura will talk about STEMI complicated with cardiac arrest. Please go ahead.
Dr. Masako, please open your microphone.
Thank you, Chairman, ladies and gentlemen. Please wait. Okay. Okay. Thank you, Chairman, ladies and gentlemen. My talk today, I will talk about the strategy for acute STEMI and non-STEMI complicated with cardiogenic arrest. The key issue is the decision making. I have nothing to disclose. Today, I will talk about the three issues. First of all, the classification of out-of-hospital cardiac arrest. Actually, the classification is very useful to guide the treatment. And secondly, I will talk about the catheterization for such kind of patient. Catheterization itself is harmful or beneficial, and who is the best candidate for coronary angiography after resuscitation. And finally, I will talk about the intervene a little bit. Usually, the outward hospital cardiac arrest will be classified into two groups. One is a non-shockable out of cardiac arrest. The other is a shockable cardiac arrest. A shockable cardiac arrest is usually associated with VF and pulseless VT. On the other hand, non-shockable out of hospital cardiac arrest associated with cardiac arrest or pulseless electrical activity. When I look at the Minnesota experience over 5 years, this paper was published in Circulation. Shockable out of hospital cardiac arrest, approximately 20% of all. In contrast, this group, the survival rate without neurological function is approximately 60%. Therefore, the shockable out of hospital cardiac arrest seems to be a good sign. And next to that, the patient with shockable out of hospital cardiac arrest will be classified in two groups. One is return of spontaneous circulation, the other is refractory VFVT. Actually, most survivors achieve return of spontaneous circulation within 15 minutes after resuscitation. And these cases are further subdivided in two groups based on the STT changes. Coronary artery disease is the most common underlying cause of shockable cardiac arrest. However, the incidence of cardiac arrest, coronary artery disease seems to be different based on STT changes. If we can find that the ST elevation after resuscitation, the incidence of significant coronary artery disease is more than 70%. And also, we can find that acute region, approximately 80% of cases. Therefore, when I look at the ESC guideline 2017, a primary PCI strategy is recommended in patients with resuscitated cardiac arrest and electrocardiogram consistent with stent. Given the high prevalence of coronary occlusion, urgent angiography within 2 hours should be considered in survivor of cardiac arrest. In this category, including unresponsive survivors and also suspicious for ongoing infarction. If patient has a presence of chest pain before arrest, or if patient has a history of established coronary artery disease, and also if patient has abnormal and certain electrocardiogram finding, in such a patient, the CAG will be recommended. Next scenario is no ST elevation. In this scenario, the significant coronary artery disease is actually less than 50%. And also, acute lesion seems to be less than 1/3 of them. Therefore, the catheterization for out of hospital cardiac arrest without ST elevation is a problem. Is it harmful or beneficial? Who is the best candidate for coronary angiography after resuscitation? Who is the right patient? When there is no evidence of STEMI on electrocardiogram, identification of patient who has arrest a coronary cause is surprisingly challenging. It's very difficult to determine which patient should undergo coronary angiography. When I think about the rationale of catheterization, catheterization itself will provide useful information for diagnosis. Actually, we can directly check the coronary lesion and the thrombotic occlusion. Therefore, the coronary angiography will guide further therapy. And also, coronary angiography will allow the immediate revascularization. The revascularization itself stabilizes the hemodynamic status and improve the prognosis. And also, coronary angiography will provide access to circulatory assist device. Previous speakers talked about the ECMO and also IVP and Impel. Such kind of access devices will stabilize the patient. However, we have to think about the dark side of catheterization. Unnecessary coronary angiography may be harmful because of the delayed intensive support and target temperature management. Electrocardiogram is the first diagnostic tool to discriminate coronary arteries. However, post-resuscitation electrocardiogram regularly show wide spread repolarization and conduction abnormality. Therefore, it's very difficult to diagnose actually coronary arteries. How about the troponin T? Troponin T is a very useful tool to diagnose acute myocardial infarction. However, again, after the resuscitation, troponin T is not useful. In this paper, clearly demonstrated, they evaluate the clinical variables associating with significant coronary arteries after resuscitation. You can see abnormal troponin T and also STT abnormality was not the predictor of the coronary artery disease. Strong predictor was the history of coronary artery disease and initial rate of VFVT. That means the shockable or non-shockable with cardiac arrest. So how to manage such kind of patient without ST elevation? Recently, actually three papers published. One is the New England Journal of 2019 coactive trial, and this year peer trials was published, and also this year meta-analysis was published. The coactive trial was published in 2019 last year. The background of this trial is that many observation studies suggested the favorable outcomes of the immediate coronary angiography, but still it's controversial. The hypothesis itself is the strategy of immediate coronary angiography could improve the prognosis compared with a conservative strategy. The hypothesis is 90 days mortality will be 45% versus 32%. Main inclusion and exclusion criteria was shown in this slide. Eligible patient was successful resuscitation patient, and STEMI and shock and obvious non-coronary cause of arrest and renal dysfunction was excluded from this study. A total of 538 resuscitated patients was included during 2015 to 2018 from 90 centers in the Netherlands. In the immediate angiography group, conducted a coronary angiography within 2 hours. And actually, when you look at the patient, more than 97% of the patients in this group, coronary angiography was conducted. And after that, thrombotic occlusion was defined 3.4%, and the revascularization was conducted approximately 40% of them. The other group is a delayed angiography after neurological recovery. In this group, coronary angiography was underwent 64.9%, and the thrombotic occlusion was defined in 7.6%, and revascularization was conducted in approximately 32%. When I look at the 90 days mortality, as you can see clearly, there is no difference. And also, these outcomes are maintained in 1 year. Peer trial, this is angiography in resuscitated patient without ST elevation. One group is angiography within 2 nerves. The other group is more than 6 nerves. Again, this trial did not demonstrate the clinical benefit of early angiography. And in this trial, carpet lesion was observed in 47% and 50% in CTO. And finally, meta-analysis are published in JACC Cardiology, Interventional Cardiology. So in this trial, meta-analysis also did not demonstrate the clinical benefit of early coronary angiography in terms of the mortality. How to interpret these findings? Look at our POCT trial. We can find the interaction in several important factors. When I look at their age, if the patient less than 70 years, maybe early angiography is beneficial. And also, if the patient has a history of coronary angiography, early angiography may be beneficial. However, it should be confirmed by hypothesis generating trials. The other group, the delayed angiography group, was basically coronary angiography was postponed after neurological recovery. However, in some patients, urgent coronary angiography was conducted. In in this group, cardiogenic shock, or if patient has a recurrent ischemic shortening arrhythmia, and if patient has a recurrent ischemia during hospitalization, in such a patient, even though the delayed group, urgent angiography was conducted. And finally, we have to think about the cause of death. Actually, the mortality was almost same. When I focus on the cause of death, also, even though the immediate group and the delayed group, the cause of death are almost identical. Most frequent cause of death was neurological problem. Neurological death was approximately 3 times higher compared with the cardiogenic or arrhythmia, cardiogenic death. Therefore, we have to think about optimal vital organ support with minimal time delay is crucial. Immediate coronary angiography will maybe not contribute to neurological recovery. We have to think about. Therefore, in 2017, ESC guideline did not recommend early angiography. Just class 2A recommended. Just without urgent angiography should be considered in patients with resuscitated cardiac arrest, but high suspicious ongoing myocardial ischemia. Therefore, we have to quick evaluation of non-coronary cause is essential, and the indication of emergent coronary angiography was in the case without poor neurological outcomes. If the patient has unwitnessed cardiac arrest, late arrival, and more than long time life support CPR, such kind of the patient should be postponed. And finally, the patient, if the patient VFVT, the incidence of coronary artery is greater than 75%, and high prevalence of the multivessel disease and also CTO is documented. Therefore, in this scenario, such kind of patient should be directly to cath. Actually, VA ECMO supported angiography evaluation in patients with refractory VFVT revealed that more than 80% of the patients have significant coronary artery disease, and also then when I look at the extent of coronary artery disease, more than 70% of the patients have multivessel disease. So therefore, the good candidate of coronary angiography out of hospital cardiac arrest without ST elevation, ESC guideline, and also lessons from COACT trial quite similar. The absence of poor neurological outcomes is essential, and also high index of suspicious ongoing ischemia is a very important factor. And also COACT trial, the young patient less than 70 and history of coronary artery disease may be some beneficial. The other side of the unshockable out of cardiac arrest patient, there is no data so far. Previously, I showed that this population is now more prevalent. Approximately 80% of the all will shock cardiac arrest, and commonly associated with non-cardiovascular disease. And strategy still the data is not limited, therefore, actually we cannot say exactly the strategy. And finally, I will show you how do you intervene in cardio. This patient is complete revascularization is essential in patient with cardiogenic arrest. Again, the culprit shock trial, the previous speaker showed that this is not beneficial. The culprit region only PCI is more better. Because the culprit shock, this trial, this included a large proportion of patients following outward cardiac arrest. More than 50% was resuscitated before randomization. Therefore, the culprit shock trial will give us some information about the strategy. So therefore, in practical, the multi-basal PCI is not recommended. Those exhibiting the poor hemodynamic responses, in such a special case, the multi-basal complete revascularization should be considered. This is our final slide. In summary, resuscitation is a part. Shockable out of cardiac arrest is a good sign, and refractive VFVT, such kind of patient is associated with a high complex and multi-basal disease. Immediate coronary angiography is very beneficial. And also in case of STEMI, immediate coronary angiography is also beneficial. However, in case of non-STEMI patient, same approach will be required. Assessment of patient-related clinical and presentation and predict the mortality and neurological recovery. And also we have to evaluate ongoing ischemia. Thank you for your attention.
Thank you very much, Prof. Open for discussion. Any questions? Dr. Wang, are you online? I know in Taiwan also you have teams that go out and use ECMO in acute resuscitation for cardiac arrest. What has your experience been in Taiwan?
Yes, in our experience is that usually it's very difficult to determine to save the brain first or to save the heart first. But nowadays, the most concept is that we have to save the brain first, because if the heart is stunning or the heart is broken, we still can use the mechanical support, or even we can use the heart transplantation, but we cannot do the brain transplantation. So always brain first. In our hospital, we have a trial to use the ECMO with deep hypothermia of the brain to deep cool the brain to below 30 Celsius degrees. So it's still undergoing a clinical trial. But in the preliminary data, we showed the very favorable neurological outcomes, and also have an oral presentation in 2017 AHA Congress. Well, so because there is a mechanical support, so we can save the brain. But if without mechanical support, then if the heart is some lesions in the coronary, I think we still needed to open the lesion as soon as possible so that return the heart to study to effective beating and the effective reasons. Otherwise, no circulation and no further hopes to say, I think.
Any other comments or questions on resuscitation? Okay. With that, then we'll move to the third speaker, Professor Chi from Malaysia, and he'll talk about optimal medical therapy, lessons learned from Courage and Ischemia trial.
Good afternoon, everyone. My name is Dr. Chi. I'm coming from Malaysia. So I think we will shift a little bit from the two previous speakers. I think the two previous speakers has given us a very fantastic overview of the acute situation in the cardiac disorder, acute cardiac event. So I'm moving the gear towards looking at those patients who actually have stable angina or chronic coronary syndrome. So this is just to illustrate the two trials that bring actually important insight. How are we actually going to manage patients with chronic coronary syndrome? Mr. Lee is a 65 years old retired medical assistant. He has background history of diabetic and hypertension for about 10 years, and he has been smoking for the past 20 years. So he came to see us essentially because of angina. He has chest discomfort after about walking upslope about 200 to 300 meters. And when we brought him in for a stress test, so the ST changes start to appear around stage 2. So she went on and get a CT coronary angio, and it actually shows a mid-RCA more than 75% stenosis. So the question that he will ask me, and I'm very sure these are the common questions that your patient asks you, is that do I need an angiography and angioplasty? This is a patient consider high risk diabetic, hypertension, smoking, and stress test positive at stage 2, and the CT scan actually shows critical stenosis in the mid-RCA. So the question is, what's the point and what's the benefit of PCI in the patient who has stable angina? Is it to reduce mortality, to reduce future chance of myocardial infarct, improve his exercise tolerance, reduce angina, or we actually see no benefit doing an angioplasty or in a bigger terms, revascularization in patients with stable angina? In other words, the topic of my talk is actually looking at Courage and Ischemic trial is actually trying to answer, does PCI in stable angina actually reduce cardiovascular death and or myocardial infarct? This is the study design of Courage study. This is published back in 2006, and subsequently the result come out about 2007. Essentially, the patient recruitment is similar to Mr. Lee. Patient must have symptomatic angina, or patient was stable after MI, or documented asymptomatic myocardial ischemic. For example, patient went for a routine health checkup and found stress test positive. On one arm, as you can see here, is patient is put on optimal medical therapy, and on the other arm is actually optimal medical therapy and angioplasty. And what we are trying to look for here is to look at whether a routine PCI in this group of symptomatic patients will actually reduce all-cause mortality and or non-fatal MI. And as you all know, the result essentially shows there's actually no difference between optimal medical therapy compared with a routine PCI. This is looking at survival free of death of any cause, all-cause mortality, and myocardial infarct. And whether a routine PCI actually reduce a future event of acute coronary syndrome, again, Courage trial actually show there's actually no difference between the PCI versus the medical therapy. And if you look at all these endpoints, that actually shows that there's actually no difference whether the patient have only single vessel disease or multi-vessel disease. Whether the patient have previous history of MI or diabetic did not change all the outcome that you have seen just now. and the outcome that you have seen just now also is similar, whether whatever the RV function is and whatever the angina class is. So this is what we see essentially shows that routine PCI did not change all the endpoint. But what does it show is that if we actually do routine PCI together with optimal medical therapy, as you can see from this graph, that the patient actually have more angina-free period compared with optimal medical therapy up to about 12 months. Now, what does that mean? It means that if we actually do routine PCI for this group of patients, for the first 12 months, compared with optimal medical therapy, PCI actually provide them more time in angina-free. They are symptomatically better. However, this benefit seems to disappear after around 1 year or so. And of course, this translates into a better quality of life among patients who actually took up a routine PCI compared with medical therapy. But again, the superiority of better quality of life among routine PCI group disappeared after 12 months. In other words, beyond 12 months, the quality of life for both groups essentially is the same. So in summary, ladies and gentlemen, COURAGE study actually show us there's actually no survival benefits between routine PCI versus optimal medical therapy alone. However, it does reduce the angina frequency and it does improve quality of life. There's a lot of limitation in the trial. So this is a slightly older trial. Most of the stent that was used was actually bare metal stent. Male patient is occupy around 85% of the total study population. Most of the patient is either from United States or Canada. And in fact, we actually look back in the nuclear imaging of the COURAGE population, up to 2/3 actually have no significant ischemia. For example, less than 10% of the heart muscle is actually suffering ischemia in nuclear imaging. So a lot of question is being asked whether what we see here in the COURAGE study, we do not see routine benefit of PCI, because these are maybe, low risk patient, not much of ischemic load. So with this result, that is the reason why they run another trial called ischemia trial, which was actually announced this year. Now, the recruitment and the inclusion criteria actually learned the lesson from COURAGE study. Essentially, they must prove patient must have severe ischemia or moderate ischemia. This is actually done by all these different kind of tests. So for patient to be recruited in ischemic trial, they must show moderate to severe ischemia based on nuclear perfusion scan, a stress echo, a cardiac MR, or exercise stress test. So this is actually to try to correct some of the limitation that we see in COURAGE study. If they actually show ischemic in this group, in this imaging study, then all patients will actually go for coronary CT scan. This is trying to exclude all those patients who are not suitable for an intervention or revascularization. For example, patients who actually have left main stem lesion, then they are excluded. Patients have very, very bad CTO or very diffuse disease, again, they are excluded. So you can see that they're actually trying to really look into comparison of revascularization plus optimal medical therapy versus just optimal medical therapy alone. So those patients who actually get into invasive strategy, then they actually follow what is the standard of care now. So they will get optimal medical therapy, they will get an angiogram, and then they refer to heart team to decide whether patient should go for PCI or should go for bypass. If the patient has very, very bad disease, not suitable for revascularization, then they will put for medical therapy alone. For those equivocal stenosis, then again, they will actually do a FFR. They use 0.8 as a cutoff point to decide whether the patient should go for intervention or not. So I think this actually reflects some of the modern practice of how you and I practice in the cath lab. On the other arm, those patients who actually randomized to conservative strategy, so they will get a lot of optimal medical therapy. They will go for PCI only if the patient have an event, for example, acute coronary syndrome, or patient actually have refractory angina, then they still can go for angioplasty or CABG, reflecting the standard of practice here. So if you want to know how many of them actually get revascularized, so in the invasive arm, up to about 79% actually receive revascularization. DES is the one that actually used most in the PCI group. This is again trying to correct the limitation that you have seen in COURAGE study. Lima graph was actually used in up to about 91.9% in the bypass group. And in the optimal medical therapy, up to about 20% actually need to go for angioplasty or revascularization because of refractory angina, or they actually have an acute event. So I think this actually reflects very good practice, right? And the ischemic trial is actually done internationally, so reflecting the global picture. I think up to about 20% was actually in Asia country. But again, it actually shows a similar endpoint, right? If you look at the primary endpoint, namely the cardiovascular death, the MI, the hospitalization for unstable angina or heart failure, or cardiac arrest, essentially there's actually no difference. In fact, for the first 2 years, the invasive strategy actually have more primary endpoint or primary event. And then after the second year onwards, you see that conservative strategy actually have more primary endpoint. This is what the same thing. You see more myocardial infarct initially in the invasive strategy, and then you see more conservative strategy has more MI after the second year or so. So again, there seems to be the benefit or harm seems to be neutralized throughout the 5 years follow up. So again, it did not show any benefit for routine invasive strategy among patients with stable angina. What you see in COURAGE, you also seeing the same thing. Patients have much better angina-free period in ischemic trial that for those patients who actually went for the routine PCI compared with conservative. Same thing, the quality of life is better among patients who actually get routine PCI. And if you actually look at the various subgroup analysis, no difference whether they are single vessel disease or multi-vessel disease, whether the patient have diabetes or CKD, whatever the degree of ischemia, whether they have moderate ischemia versus severe ischemia, the outcome that you have seen from the graph just now is the same, whether proximal LAD is involved or no difference as far as routine PCI versus optimal medical therapy. So again, ischemic trials have actually showed a similar result like COURAGE, no survival benefit, reduce angina frequency, and improve quality of life. But they also have limitation. Although it have tried to correct some of the limitation done in COURAGE study, but I think some of the things that you see here are the limitation. It's still an open label, a real world registry. There's actually no sham procedure like the orbital study. So I think the patient know and the physician know what was done to the patient. This may actually change the outcome of the study. So coming back to our patient, so you see that this patient actually have positive stress test, and the CT scan actually shows severe stenosis. So what is the benefit of PCI in him based on the COURAGE and ischemic study? Definitely, we are not looking at reduced mortality. We are not looking at reduced myocardial infarct. So with all this COURAGE study, ischemic study, nowadays when we meet up with the patient in this kind of situation, those patients with stable angina, I think we actually need to involve the patient. We talked to him for a long time, looking at pros and cons of PCI in him. We stress again the importance of lifestyle modification, especially stopping smoking. We also looking at a very aggressive medical therapy, which has been shown in ischemic trial and COURAGE now to be as good as routine PCI in reducing the outcome. Now, just a quick word on what do you mean by optimal medical therapy in ischemic. So as you can see here, that's divided into two. Firstly is a behavior risk factor. Smoking must stop. Patient must be more active, and patient must look at the diet to reduce the saturated fat. For medication, in this trial, they're actually very aggressive. Blood pressure must be less than 130. LDL must be less than 1.8. They must reduce their weight, and the HbA1c is around less than 8. Now, of course, this reflects some of the older medication. For the past 1 or 2 years, we have newer medication. For example, PCSK9 in this trial actually show mortality benefit or MACE benefit compared with standard therapy. We also now among diabetic patients, SGLT2 inhibitors in this EMPIRIC study also show good outcome in MACE, and recently also GLP-1 semaglutide in Pioneer 6 also have shown benefit. So I think definitely there are more in medical therapy that we can actually help this group of patients to reduce the outcome, the MACE event. But I'm very sure you are seeing this kind of patient like I'm seeing in my clinic. You know? They have been so exposed to the block in the vessel, and you must do a balloon, you must do a stent. So I get a lot of feedback from my patient after this kind of lengthy discussion. So I have a block and you tell me no need to put a stent. I mean, it's very difficult sometimes to actually handle this kind of patient. So after lengthy discussion, Mr. Lee still insists of doing something to the block. So we oblige and we actually done a PCI to the RCA with a FFR guidance. Of course, whatever we see in ischemic trial, lifestyle modification definitely has been stressed upon, and these are the medication, long list of medication that this patient is on. So this is just an example telling all of us how the courage and ischemic trial actually have changed our practice. We need to involve the patient more in the discussion. So what the two trials have actually showed us is that there actually no benefit versus optimal medical therapy as far as mortality is concerned, as far as future SCS event is concerned. In routine PCI, it does reduce angina and it does improve the quality of life. I think these are the things that we need to get across to the patient. I think from now on, looking at how we should do PCI with stable angina, I think it has to be a shared decision making. However, based on what I have done to Mr. Lee, you know that there's a lot of resistance as far as market force is concerned. The stent company, the patient expectation, your colleagues' expectation. I think it will take a while for whatever we see from courage and ischemic study to actually translate into our practice. So with that, thank you very much.
Thank you very much, Prof, for that presentation. I'd like our colleagues to start a panel discussion. My first question to the panelists, most of you are invasive cardiologists. Has the ischemia or courage trials affected your practice in your regions and hospitals? Start with you from Malaysia. Has it affected any effect, do you think?
Well, I have to say that it doesn't change much. I have shown you just now. So we try to incorporate whatever we learn, but unfortunately, patients are being sort of well educated from media and from past experience that whenever the patient have a block based on CT scan or stress test positive, they expect something to be done. So if you do not want to do it because you believe in courage or ischemia, I'm very sure some other intervention cardiologist down the street will do something. I'm not sure. I think this is what happened in Malaysia. I'm not sure in Taiwan or in Japan whether this is a similar thing. Yeah.
Mahmoud, has it affected your practice?
Yeah, I mean, you know, we have a situation where patients have a lot of options. So what ends up happening usually is I don't fix it. They go down to the next guy and tells them why didn't you fix it, and you know, should have taken care of it. So I think it needs a more systematic approach. As long as you have free market forces that, as Dr. Chi mentioned, where patients have the option of going to other things, it's a fundamental mentality shift that needs to happen, where people think I have blocked arteries and fixing it is not going to help me or prevent something bad from happening. It's really hard it's easy to sell patients on it, to open it, and it's very hard. It's like giving antibiotics for a cold. It's very easy to give the antibiotics, but it's very hard to convince them they don't need the antibiotics. It's the same thing with the stent in this setting.
How are things in Japan, Professor Masoto?
Thank you very much. I think it's very difficult to say. Actually, we don't have no data so far. However, actually, I think the number of the PCI cases gradually decreasing. I think so. Especially, as you know, after COVID, number of the PCI cases is decreasing dramatically. Therefore, we cannot find out it's the effect of the trial data or COVID. It's very difficult to say. However, anyway, many physicians believe that routine PCI is not useful. Everybody can agree that with that. So we have to think about the indication more precisely. I think a little bit the attitude to PCI is changing. It's my just a feeling.
Dr. Chen is also online with us now. He's a professor of cardiac surgery from the National Taiwan University. Hello, Dr. Chen. I'd like to go back to shock patients. If we have Mahmoud, if we have a shock patient in a referring hospital, what is your current practice now? So somebody calls you and says, I have an acute MI and the patient is in shock in my hospital. What do you tell them to do, and what will you do when the patient comes to your hospital?
I think for us,
first of all,
please,
hello?
Dr. Chen, please.
Chen, do you want to start?
Hello, can you
Yes.
hear?
Yes.
Okay. The question is divided to two questions. First is in hospital, the other is out of hospital. First, I see in hospital, if it's only, if the patient was under shock, and only shock, not arrest. If the arrest, we will put on the ECMO first, then we go to the cath lab. If under shock, we will we will seek for the reason, the cause of the shock, including the septics, including the cardiogenic. Most of the cardiogenic, so we will do the echo and do the Swangang first, then to evaluation the hemodynamics. Then we will seek for the mechanical problem, then seek for the vessel problem, such as the cath lab. Then if the patient was over the hypoperfusion, such as the renal insufficiency or hepatic insufficiency, we will put on the mechanical support, and it depends on the ejection the ejection status when he had shock. And the patient was out of hospital is another issue. In another hospital, the transportation will be a critical issue. So if not so far and the inotropic not so high, we will encourage them to transfer directly. But if not, I will put on the IBP, put on the ECMO, and go for the transportation.
Dr. Mahmoud?
Yeah, I mean, we're still a pretty young system, so we're not as protocolized as we'd like it to be. Most of the other hospitals only have access to balloon pumps, so we usually ask them to put in a balloon pump. We've recently started to do more of sending out teams for more advanced supports patients that can be transported and put in ECMOs or Impellas on site. I think that's going to be a better strategy going forward for us, but it's still an evolution, at least on our side.
Yeah, this is becoming an evolution, as you said. And I think in Taiwan, you have teams. Do you have teams that go out and put in ECMO? Particularly in cardiac arrest.
Yeah, sure. We have, but we don't have the Impera in my country.
And in Japan?
Actually, so Impera is available. However, just 2 years ago, Impera was approved, and the penetration in Impera in Japan is not so high. So just limited in several hospitals. So therefore, many patients are treated by IBP or ECMO. I think so.
I want to, excuse me, I want to know why the reason the Japan not so many impeller in Japan.
Just a reason why the government doesn't want to use
Okay.
because it's expensive.
Well, cost is an important issue. You know, the Impella is I don't know how it is in each individual market, but it's generally about 10 to 15 times the price of a balloon pump at least, and at least 4 to 5 times the price of ECMO. So I mean, it's understandable that various systems, it's a big investment that needs to be made, and I don't know,
exactly.
eventually the cost will come down.
Yeah, exactly. However, the Japanese government just limited to several hospitals. They decided to use several. We need several criteria. Otherwise, we cannot use.
Mhm.
Any other questions on shock resuscitation?
I want to ask another issue. I know the shock IVP2 trial already tell all of the world say IVP is useless for the cardiogenic shock, but I want to know how about the really world condition in Japan, in the other country, especially in the Asia country.
Anybody want to start with that?
I can.
So use of IABP. Sorry?
You know, the IVP trial, shock 1 or shock 2 trial in NEJM, in Germany and the United States, the study also tell us IVP is not good, it's not superior result compared with the inotropic use only. So, but in my hospital, the cardiologist still use the IV quite frequently. So I want to know how the condition in the other countries in Asia.
I see. So in Japan, the number of the IABP usage is decreasing. I think so, based on the data.
Yeah.
What about in Malaysia?
I think in Malaysia, we actually start to cut down the use of IIPP after the result. Personally, frankly speaking, when you actually see the patient come in with ACS with cardiogenic shock, the IPP doesn't really work that well. Yeah, I think it's more like treating the doctors rather than treating the patient. Yeah.
Mahmoud, what cases would you use IABP?
Yeah, I mean, I think that's the same with us. You know, when patients have true full-on shock and hypoperfusion, we're not really using a balloon pump. So it's more of in the milder cases or patients just kind of support them through. But more advanced, I think we're using earlier ECMO and Impella when we feel the cost is not too crazy.
If we go back to the resuscitated patients with non-STEMI, which patients would you take to the cath lab?
It depends on the philosophy of the cardiology of the surgeon. Maybe the only issue that every physician care is the neurological. If the neurological intake, I think everybody will go to the cath lab. But if the patient unconscious, for example, the E1M2, did everybody get to the cath lab or just leave alone wait the conscious recovery?
Mm-hmm.
In my hospital, there are different philosophy for each cardiology. Somebody will say, okay, let's go for the cath lab for every cases. But somebody say, okay, just wait for the conscious recovery. And I always say, when the patient are under resuscitation, ECMO is just at the time, not cure the patient. It's just wait and see. So my personal attitude is go to the cath for as possible and treat them, then wait for his conscious. But somebody will reverse. You will wait the conscious, then treat later. I think it's different philosophy.
Dr. Masato?
Thank you very much. It's a very difficult question. Actually, the observational data is highly biased. If the patient prolonged long time resuscitation, such kind of patient will not be sent to the culture. And if the patient is a young guy and he has a history of coronary disease, already we know that such kind of patient should be transferred to culture. Therefore, actually, we don't have enough data in this situation. And in a hospital, so actually, when I look at the attitude of the insurance, based on the hospital, quite different. Some hospital highly conservative. Some hospital so aggressive. Every patient go to control. So therefore, still, this is controversial, and we don't have a clear answer, I think.
Definitely.
Yeah, I mean, basically from our side, if a patient has high evidence of ischemia, so if there's evidence of ongoing ischemia, relatively shorter arrest, and the neural status you don't think is fully gone or has some reasonable neural status, then we push those earlier. But if the resuscitated ECG looks okay and patient doesn't have any and prolonged arrest, we will tend to sit on those. So it's kind of a depending if you have some kind of evidence that's pushing you to ischemia, being the etiology, we push earlier versus the rest we kind of will sit on until we get a better understanding of what's going on.
Do you have any other questions or comments on our subjects today? We didn't get any questions online. No.
No.
No other issues that you would like to discuss about these questions? Okay, then I think we're going to be finishing early then today. I'd like to
thank you.
thank our speakers and our co-chairs for this session on acute coronary syndromes. I found it very enjoyable and controversial, and thank you all for your presentations and your time. I would like to thank the Asia Pacific Society of Cardiology and the people behind the Asia Pacific Society of Cardiology Cloud webinars. Thank you very much. Bye-bye.
Thank you.
Bye-bye.
Bye.
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 Thank you.
Bye.
Bye.